Okay, next. Okay, so hepatocellular carcinoma represents about the 17.5 of primary liver cancer and constitute a major public health problem. The major risk factor for the development of hepatocellular carcinoma is chronic damage to the liver, in particular cirrhosis. The risk factor for development of cirrhosis are excess alcohol consumption, infection with virus such as hepatitis B and C, obesity, and diabetes. Many of these causes are related to lifestyle, and implementation of a national policies to limit alcohol intake and encourage healthy living could have a real impact in reducing the number of people developing cirrhosis and hepatocellular carcinoma in the future. So next. Okay, while previous chronic viral hepatitis was the most common etiology of chronic liver disease leading to hepatocellular carcinoma, successful treatment and prevention program for viral hepatitis have reduced the prevalence of this in recent years. Simultaneously, the rate of mesothelioma T have increased significantly, and large United States healthcare database show that the hepatocellular carcinoma cases identified the muscle D as the most common form of chronic liver disease. Next. And the incidence of about Stefano says of the muscle D are rapidly rising worldwide. The global prevalence is approximately of 25%. And obesity and insulin resistance led to a chronic inflammation, altered the lipid metabolism, and this is a pro-carcinogenic state that promotes the development of the hepatocellular carcinoma. Next. And also, the impact of muscle D to liver transplantation is the proportion of NASH and hepatocellular carcinoma increased of 9-fold from 2.7% in 2002 to 25%. And the data show that growing evidence that at the present, muscle D is the most important driver of hepatocellular carcinoma related to liver transplantation in the United States. So next. So carcinogenic process of hepatocellular carcinoma is very complex and is characterized about modify and non-modify risk factor. Metabolic disease, most notable diabetes and obesity, along with other metabolic traits such hypertension and dyslipidemia, are associated with an increased risk of hepatocellular carcinoma lifestyle-related modified factors such as certain food, dietary partner, and physical activity are associated with a reduced risk of hepatocellular carcinoma. Next. Next. So for the weight loss, back. So for the weight loss, we don't have a direct evidence of reduced hepatocellular carcinoma, but evidence say that weight loss reduce muscle D associated hepatocellular carcinoma. And previous clinical studies have shown beneficial effect on weight loss activity, but not on fibrosis and regression of fibrosis of weight loss. So next. The other study show the bariatric surgery. Currently, the two predominant surgical procedures of weight loss after bariatric surgery, rather than the lifestyle in patients with NAFLD and obesity, was evaluated in a large meta-analysis. And the histological resolution of steatosis, inflammation, and fibrosis was observed in respective patients. However, 12 of patients show post-operative worsening of histological disease activity. So next. And another field of the recent years is of the use of endoscopy and the use of a bariatric endoscopy. There are two types of bariatric endoscopy. First one is the position of intragastric balloon or the endoscopic sleeve gastroplasty. The two FDA-approved gastric balloon devices are Orbera and Obalon. Next. The use of endoscopic gastric regression in that study published on endoscopy showed that the use of gastric regression reduced the portosystemic pressure gradient, and the measure of PPG was with echoendoscopy. And the reduce of PPG decreased the risk of hepatic decompensation and also show that endoscopic gas regression is an effective endoscopic weight loss procedure. Next. And in a study of gastroenterology, the use of endoscopic gastroplasty showed that the patient hepatic steatosis index score improved significantly, decreasing by 4 points, and 24 patients improved the risk of hepatic steatosis from 3.4 to indeterminate F0. Only one patient experienced an increase in estimated risk of fibrosis. Next. So we have another therapy. The another therapy is the liraglutide or semaglutide. But the warning is that this therapy is not approved for muscle D or MASH. Given the overlap of MASH with diabetes and obesity, glucagon-like peptide receptor have been proposed as a potential treatment option. Although this target is not approved for muscle D or MASH. However, their mechanism of action target common metabolic defect and lipotoxicity. So next, and in this study, we can divide it, okay, next slide. Okay, next please. Okay, we can divide it and stratify the patient in high risk, low risk, or intermediate high risk. All patients with all risk group, the modified factor are Mediterranean diet, exercise, stop smoking, and for intermediate on high risk, we have new therapy. But if the patient have MASH with diabetes, we can use the glucagon-like receptor. But now in next please. Now in a recent trial, we have a new target therapy that is the resmetirom. So in a recently a systematic review of 30 observational students focused on the diet Mediterranean and the relationship between Mediterranean diet and hepatocellular carcinoma show that the adherence to the Mediterranean diet were significantly associated with a decreased risk of hepatocellular carcinoma with an odds ratio of 0.151, and the Mediterranean diet is recommended by European guidelines of NAFLD. Okay, next. And in this meta-analysis, we show the forest plot for only for randomized controlled trial studies included the reduce of liver stiffness with the use of Mediterranean diet, and as indicate that Mediterranean diet decrease liver stiffness. Also, next. Another important factor is physical activity. Also, the problem in hepatocellular carcinoma is sarcopenia and frailty that are common complications of liver cancer and end-stage liver disease, because inflammatory cytokines released by tumor can reduce protein synthesis or cause protein denaturation. To treat this condition, nutrient supplementation and physical activity are used. Early intervention, such as nutritional support and exercise therapy, can help to prevent wasting of muscle, impact in weight lifting and to reduce the development of hepatocellular carcinoma. Okay, next. And in a work of Journal of Hepatology, we know that we are more therapy that are chemoprevention of hepatocellular carcinoma, for example, metformina, but we don't have a randomized control trial for metformina. We have only one trial that was stopped for an reduced enrollment of patients of hepatocellular carcinoma linked to virus C. And another study, another meta-analysis of only randomized control trial showed that the use of statin is a chemopreventive effect on the development of hepatocellular carcinoma. Okay, next. And FDA have developed the use of resmetirom for patients with muscle D. We don't have data if resmetirom reduce the incidence of hepatocellular carcinoma, but we have promising data of the use of resmetirom in patients with muscle D, and is it ongoing trial of the reduce of decompensation event with the use of resmetirom. Okay, next. But this factor and this lifestyle factor, what is the role of this factor in the pre-transplant obesity has been found to be an independent risk factor for long-term mortality, graft dysfunction, and increased post-operative event in patients undergoing liver transplantation. Data has shown that patients have concomitant obesity and diabetes mellitus have a double total of risk of complication, and concomitant obesity and diabetes is associated with reduced post-liver transplant survival and recurrence in hepatocellular carcinoma. So next. Okay, in this study showed that obesity may be an increased risk of perioperative respiratory and infectious complication, and it is necessary to establish preventive strategies. And bariatric surgery is an alternative treatment for obesity and bariatric endoscopy, but the ideal timing regarding liver transplantation is still unknown. Next. And also, there was an increase of incidence that complication in overweight and obesity patient compared with the non-obese patient in liver transplantation setting, and the incidence of recurrence of hepatocellular carcinoma was the double in the presence of overweight and obesity, and time to recurrence also decreases significantly. Okay, next. And the very big problem in the setting of a liver transplantation is the de novo metabolic syndrome, because the development of the de novo metabolic syndrome was observed in patients transplanted for muscle D and cryptogenetic cirrhosis, and the risk of cardiovascular event is a very important factor that it is critical to develop is a factor that increase the risk and reduce the mortality of patients with a new graft. And it's very important to diagnostic strategy to identify the high-risk patient for reduce the mortality after liver transplantation. Next. And also factors such as the largest tumor size, microvascular invasion, lack of tumor capsule, post-transplant metabolic dysfunction, associated fatty liver disease, and decreased post-transplant lymphocyte percent were related to an increased risk of recurrence of hepatocellular carcinoma. Okay, next please. And now we want to show us a case report. This is a 65 years old patient with a new diagnosis of cirrhosis muscle D, complicated by a large hepatocellular carcinoma of the right lobe. Comorbidity was hypertension and diabetes. Okay, next. Next, please. So after an multidisciplinary boarding, we decided to undergo the radioembolization of the hepatocellular carcinoma of the right lobe. And next, please. And also, because the obesity of patient, we take an intragastric balloon and we achieve a reduce of 15 kilograms in 2 months. Okay, next. So the next step and the next aim for this patient is the liver transplantation. And we start the workup for liver transplantation after radioembolization. So next. But it's very important that the backbone for any bariatric program is designing an intervention program that involves nutritional intervention in the form of low-calorie diet, physical activity, behavior change, overcome a physical age barrier to achieve the best for the patient. Okay? Next. No, back. So the take-home message, over the past decade, every post-transplantation outcome have significantly improved, and metabolic complication, cardiovascular disease, renal dysfunction, extrahepatic malignancy, and hepatocellular carcinoma play a major role in long-term morbidity and mortality of liver transplantation patients. A long-term post-transplant management is very complex and requires cross-follow